trainer. So the next slot is about challenges in managing drug-drug interactions with psychotropics. It is a technical topic, but I'm not going to put in a lot of facts because we are not, we are human beings. Okay, facts is not the right word. It's not going to be very, very technical with a lot of packed information because we are human beings. We are not computers. That is my my basis for this. Even computers need external hard drive gun. You need additional storage space. For me, as long as you are aware that something might be going on, that you're able to recognize problems when they arise, the facts, the information, the specific enzymes, or the specific interactions, you can always look up. You can always look up on the internet. You can always look up in textbooks. But the most important thing is that you must be aware that something is going on. So we'll be talking about clinically significant drug-drug interactions, DDIs for short, versus theoretical ones. And the potential mechanism simplified, and we'll be looking at some case illustrations also. The common, not so common, and the often missed. So what are drug interactions first? You're taking one drug and then you take another drug into the body, and that affects how the first drug behaves in your body. That is a drug-drug interaction. Interactions can also happen between drug and food, dairy products and iron supplements, drug and supplements, drug and medical conditions. And another thing which I didn't put here is the role of genetics. Pharmacogenomics, pharmacogenetics, and tailored pharmaceutics, I believe, are the way of the future. It's something that is a very exciting area of research. So if there's something that you're into, I would encourage you to look into it. So drug interactions are important, a concern, because they can do many things. They can decrease the action of the drugs, they can increase the action of the drugs, leading to toxicity or adverse effects. And the reason that I put this photo here is because drug-drug interactions, they're very complicated. When we learn our study in school, we study in pharmacy school, everything is like textbook case, right? It's a very linear reaction. This happens, then you add this, then this happens. Unfortunately, in the real world, in a real patient, things are not that simple. It's very complicated. You can look at all the threads because medications can be, drug metabolism is very specific to a type of metabolism, right? Can it involve either phase 1 or phase 2, or even more phases, both phases. So the most commonly is like phase 1 through the liver, oxidative metabolism. And at the same time, medications can be both inhibitors or inducers of one or more cytochrome P450 enzymes. So it's a very complicated relationship, and a lot of these relationships can be theoretical. They can happen, but they may not affect the patient. So this is where you have to learn to differentiate, to distinguish what is important and what is not. Otherwise, everything also cannot give. Okay? So DDIs are hard to detect, often missed, as you can imagine, because it's so complicated. And the symptoms can actually mimic a new disease or a adverse effect. So we're looking at poor treatment outcomes as well. The patient doesn't respond or develops side effects, or develops new symptoms that causes them to stop taking the medication. Serious adverse events is also a concern. It's even more complicated when you have patients who are on polypharmacy and they have multiple comorbidities. This is most often seen in aging populations. Can imagine if you've seen patients who have diabetes, hypertension, they have schizophrenia, they have also some depressive symptoms. So it's like 10 or more medications. And the more medications that you have, the higher risk that you have of a drug-drug interactions. So whenever you see a patient, an older patient or otherwise, who has a lot of drugs, be alert. There could possibly be a DDI in there. Aging also causes changes in pharmacokinetic parameters. you have changes in metabolism and excretion, so you have higher concentrations in the body, and these could lead to toxicity and such. So those adjustments are important, even if the patient has been taking something for a very long time without any issues. They may develop problems later on as they age because their body is changing, right? So genetics, we talk about that, hepatic or renal impairment, and also drug-dependent factors such as narrow therapeutic index drugs. So looking into the types of DDIs, we're going to focus on pharmacokinetic ones, where the second drug modifies the ADME process. So this is defined as the body's effect on the drug. You take a drug and your body does something to it. Pharmacokinetic DDI alters the availability of the active drug at therapeutic site. So either gets too much or it gets too little. Whereas for pharmacodynamic, it's quite common sense. The concomitant drugs that you take, they act on similar target receptor sites. So this is what the drug is doing to your body, not what your body is doing to the drug. And this means that you have additive effects. It either enhances or weakens the intended physiologic effect of the drug. Example, a very, very simple example, you're taking antipsychotic and you're also taking Piriton for flu. So both of these are sedative, right? They all act on the histaminergic receptors. So you have an extra sleepy person. So looking on our case illustrations, this family needs to be introduced. They're very, very important in terms of pharmacokinetic interactions. They are VVVIP in the phase 1 oxidative metabolism process. And out of the many members of this family, there are 6 families that are responsible for more than 90% of the activity. And out of these 6 people, 6 members, you have 3 who are extra important. So they are sort of the big brothers the taiko 3A4, 2D6, 1A2. So 3A4, 2D6, and 1A2. Now, my colleague Nafisa talked about carbamazepine yesterday. She talked about TDM, the dosing, and everything. And we'll be looking at some case illustrations whereby this carbamazepine creates some problems. So case 1 is an unexpected pregnancy. So this is a 39-year-old woman. She's multiparous, which means that she's had children before. She's got bipolar disorder and she's maintaining well on the same treatment for over 10 months. And she's also compliant to oral contraceptives. But suddenly she's pregnant. So why did she become pregnant? 10 months, she's taking medication, she is compliant, she's well, but suddenly she's pregnant. So carbamazepine induces 3A4. 3A4 metabolizes oral contraceptives. So when that happens, you have decreased contraceptive levels, contraceptive failure, right? But the next question would be, why was there a 10-month delay? Well, you need time for enzyme induction. It doesn't just happen overnight. The effects, it happens within 2 weeks. We'll look at this a bit later, but it doesn't happen so fast. And you also need time for successful conception. So this is dangerous. We know that carbamazepine is teratogenic. So this woman was doing the responsible thing. She was doing birth control. She was doing family planning. She knew she was taking carbamazepine. So she needed to be sure that the medication that she's taking does not harm her unborn child. But then this happens. For case 2, let's look at relapse in schizophrenia. So this, again, our patients in these illustrations are very compliant. They're all very good. He's well maintained on quetiapine, but he suffered relapse 9 months after starting medication for epilepsy. So why did this happen? Carbamazepine induces 3A4, and 3A4 affects a lot of psychotropic drugs. You can see all of them down there in different classes: antipsychotics, antidepressants, sedatives, and quetiapine is right there. So when you give carbamazepine together with any of its drugs that it induces, you may need to compensate with higher doses. It's something that we'll discuss later. Again, why was there a 9-month lag? The time needed for enzyme induction, it can take up to 2 weeks for enough quantities, significant quantities of the new enzyme to be synthesized, right? So this takes time. And the second bit would be relapse doesn't happen overnight, because in schizophrenia, it generally occurs several months after non-compliance. So it's very gradual, it's not sudden. And because of this time lag, they may result in failure to recognize DDIs when they happen. And this is where pharmacists actually do play a role, important role. I like to think of pharmacists as investigators, like detectives. I'm not sure whether you're all old enough to know there's a show called House. So Dr. House does a lot of investigation. He backtracks, he checks the patient's history and everything. And this is partly what we do as well. We do medication reconciliation. We check the patient's history, we ask questions, we interview. So if something isn't quite right, the patient compliant, everything okay, suddenly something happened. You have to ask questions, you have to think, you have to be curious, you have to investigate, okay? So that you may detect, DDIs that are often missed. So, pointed out earlier, okay, mute right now. Alprazolam is also affected by carbamazepine, zolpidem, even calcium channel blockers can be affected. The efficacy can be affected by carbamazepine. You can see that more than 50% right here, more than 50% of drugs that we use in medicine are metabolized by 3A4. So it's really a VVVIP. 3A4 can also be induced. We can also be induced by, apart from carbamazepine, the anti-epileptic is looking at phenobarbital, phenytoin. The TB medicines are very, very problematic, especially rifampicin, and which is still very commonly used for TB, right? And herbs like St. John's wort, which is a herb with antidepressant properties. I have not seen it sold here, but you never know. Some patients may actually buy it from overseas. So always do medication reconciliation, always ask. Next, carbamazepine neurotoxicity. This is a patient with epilepsy. He's on carbamazepine and well maintained everything. 2 days after starting an antibiotic for sore throat, he started experiencing double vision, slurred speech, and other symptoms of incoordination, which you would recognize as signs of carbamazepine toxicity. Now, what happened? Which antibiotic did he receive? Does anyone have any sort of idea? Do you want to take a guess? Okay, very silent. It's okay. The next slide will tell you the answer. Erythromycin. Erythromycin, I realize, is not a very common antibiotic, but it is used in specific conditions. For example, if there's penicillin allergy. Macrolide antibiotics such as erythromycin, clarithromycin, but not azithro, inhibit 3A4. And carbamazepine is both a substrate and an inducer of 3A4. Remember what I said about things being really complicated. So this is a very complicated relationship. So erythromycin decrease the metabolism of carbamazepine, leading to toxicity. For inhibition, earlier we were talking about induction, right? So in induction, we are talking about inhibition now. Effect is immediate. Okay, it's immediate because you're talking about receptor sites and everything, but it takes a few days for the drug levels to actually rise to unacceptable levels. So again, the effects of DDIs, they're not immediate. They can be gradual, and that's why they're so hard to detect. So points to note for carbamazepine: always discuss with the prescriber, discuss with the patient about possible interactions and things to watch out for. Look through the medication list and history, to check if they are co-prescribed drugs that are metabolized by 3A4. Monitor TDM, like what we talked about yesterday, and also possibly switch to other alternatives which has no significant interactions. These are similar principles which should be considered for all drug interactions, and that requires a discussion between you, the prescriber, and the patient as well. Next, antidepressants. So now we're looking at 2D6, 1A2. 2D6, 1A2. Breast cancer, antidepressants are often prescribed in women with breast cancer. Depression and anxiety is very common in persons who are suffering from cancer, but it's also prescribed for hot flushes from chemically induced menopause. And the thing is, there are antidepressants which can cause treatment failure in cancer. And treatment failure in cancer means possible fatal effects lah. So tamoxifen, we're looking at tamoxifen as an example. Tamoxifen is actually inactive. So you need it to be metabolized by 2D6 to become its active drug. Okay, so inactive, it needs to become active, it needs 2D6. Whatever that inhibits or induces the metabolism of 2D6 is going to affect tamoxifen. So 2D6 inhibitors, you can see all of these are actually antidepressants, different sorts and different classes of antidepressants. They all inhibit 2D6 to a certain extent. So you should avoid it with tamoxifen. These are SSRIs, which are a class of antidepressants. They're also used to treat anxiety, if you remember from yesterday's lecture. They inhibit several liver enzymes, several of the cytochrome P450 family. The ones highlighted in red are more problematic. Fluoxetine, fluoxamine, these are more problematic. They do affect to a more severe extent. The ones that are more neutral is escitalopram and citalopram. Escitalopram is available in KKM and you will see it being used. Citalopram is not. So unlike 3A4, 2D6 is set to be not inducible. Therefore, levels of drugs metabolized by 2D6 may rise because it's been inhibited, but it will not fall due to enzyme induction. So how long do the effects of inhibition last? Until the drug is washed out from the body. So we're looking at 5 half-lives. And then after that, it can take up to 2 weeks for the new enzyme to be synthesized. So again, you're looking at quite long lah. Remember when I said about problematic drugs? Fluoxetine has a very, very long half-life. It's a half-life of 4 to 6 days. Active metabolite 9 days. So it will take a very long time for this particular drug, this particular antidepressant to be washed out. So it's not the best choice if there are many other drugs that the patient is taking and there are possible DDIs. So fluoxetine is not an ideal choice lah. Okay, fluvoxamine, commonly we call it Luvox, the brand name. It is a 1A2 inhibitor, and this is a problem with clozapine and olanzapine because it increases the plasma levels of clozapine and olanzapine, which can lead to higher risk of adverse events. For 2D6 is also an inhibitor, and this affects risperidone. At the same time, for a non-psychiatric context, it affects oxycodone, codeine, and tramadol. So the analgesic will not work for that patient if he or she is also taking fluvoxamine. So remember that this is an issue because you have patients with chronic pain conditions, or they could have cancer and they are prescribed all of these pain medications. You give them fluvoxamine as well, you're creating a problem down the line. Tricyclic antidepressants, the most common would be amitriptyline. It's not so commonly used anymore because we have so many other better alternatives, but it is sometimes still used, even in non-psychiatric conditions for pain, for chronic pain. So a depressed patient, in this context is depressed patient. He has TB, he failed to respond to amitriptyline. Why? Because of rifampicin. Rifampicin is very annoying. It's very problematic. It's a useful drug for TB, but it is very problematic because of its drug interactions. It induces all these 3A4, 1A2, C19, C9, and P glycoprotein, which is involved in phase 2 metabolism. So because of this, it affects a lot of psychiatric drugs, antidepressants, antipsychotics, and sedatives. Next, we're going to be looking at smoking. Why am I putting smoking here? Smoking and 1A2. A lot of psychiatric patients, a lot of patients who are on antipsychotics, who have schizophrenia smoke. It is something that they do to, in theory, it is said to because they want to mitigate the side effects of antipsychotics. The sedation, the slowness, the bluntness. In theory, it is said that it is because of this reason. So this is a 38-year-old man admitted. He has been maintained on olanzapine 50 milligrams for 5 years without any issues, no complaint, no nothing. He smokes 1 pack a day, sometimes more. He was admitted for relapsed schizophrenia. And on admission, they continued on him on the same dose of olanzapine. And eventually, they noticed he started experiencing increased drowsiness and tremors. All these side effects lah. Why? It's because of he's been smoking 1 pack or more a day. There are aromatic hydrocarbons in tobacco smoke that induce 1A2, and this is a very significant interaction. It can reduce plasma levels of antipsychotics, such as olanzapine and clozapine, by as much as 50%. It's a lot. So when you're dealing with this heavy smoking as an outpatient, you're looking at poor treatment outcomes. And you may need to consider increasing the dose of the affected drug. Remember, a patient is outside taking this dose of antipsychotics. At the same time, he is smoking a lot, more than a pack a day. So the drug is not working. Okay, there's not enough of it in the patient's blood. But when the patient comes into the hospital, is admitted for whatever reason, not necessarily a psychiatric hospital, it could be admitted for surgical intervention or some sort of medical problem. Of course, they cannot smoke in the hospital. So suddenly they stop smoking. And this may trigger emergent EPS symptoms because when you stop smoking, it can take as little as 1 week for your enzymes to return to baseline levels. Okay, within 1 week, you stop smoking, your enzymes can return to baseline levels. So then the patient start experiencing all the side effects lah. Okay, so if you assess smoking history, memang is a very heavy smoker, suddenly cannot smoke, is also on the same dose of antipsychotics, you may need to discuss with the prescriber, consider reducing the dose of the affected drug. Okay, looking at lithium, again we talked about this yesterday, or rather Nafisa talked about this yesterday. Lithium is almost exclusively renally excreted. So whatever drug or medical condition that affects the kidneys, it will affect lithium. So we have a bipolar patient, well maintained on lithium, they experience breakthrough mania, but there's no changes in the medication, and this patient is well maintained, meaning that they are compliant. Okay. After talking to the patient, and assessing their lifestyle, you realize that the patient is a very heavy coffee drinker. For example, like me lah, I drink 3, 4, 5 cups of coffee a day. It's like drinking water. But caffeine and alcohol as well are diuretics. So you need what it does, it lowers the level and hence the efficacy of lithium. When you reduce or stop intake, it can increase the levels back. So lifestyle monitoring is essential for lithium patients. It has such a narrow therapeutic window, and this is the part of the counseling that we have to do for patients before starting lithium and throughout when they are taking lithium. And lithium toxicity and hypertension. So now we have this person who is experiencing signs of toxicity. This is not the first scenario was when the lithium is not working because levels are not enough. But for this patient, he is experiencing toxicity after starting treatment for hypertension. So keyword is he only started experiencing toxicity after starting treatment for hypertension. Why? So lithium has a complicated relationship with thiazides and ACE inhibitors. Thiazide and loop diuretics, they lower water and sodium level, and this causes more reabsorption of lithium in the proximal tubers. For the diagram and everything, you can go look up yourself. Just be aware that that this can happen. ACE inhibitors also can raise serum lithium through a slightly different mechanism. So frequent monitoring on your GFR and your plasma lithium. Again, plasma lithium is the monitoring is only done in Sarawak, is only done in Hospital Sentosa, unfortunately. So in those scenarios where monitoring is very difficult, really talk to your patient, really educate them on what to do, on what not to do. For as far as I know, Hospital Sentosa is the only center in Borneo that has lithium reagent. So very hard lah. Okay, it's very hard to monitor very frequently. Okay, lithium and rheumatoid arthritis. So this patient, she developed toxicity, tremors, side effects after starting treatment for rheumatoid arthritis. Why? The patient was started on ibuprofen, it's an NSAID for pain, and this increased her serum lithium. The many NSAIDs decrease renal clearance of lithium and increase lithium levels. Because through these mechanisms, NSAIDs inhibit synthesis of the renal prostaglandin, decreases the renal blood flow, and possibly also increases renal reabsorption of sodium and lithium. So even in the context of a community pharmacist, that's why sometimes you need to ask the patient taking something else. NSAIDs are so easily available over the counter for any sort of pain. You can just buy anywhere. So the patient is taking lithium, please educate. There's certain ubat that you have to be careful of. Please inform before you take, and specifically maybe just also inform them that NSAIDs is a big problem because it's so commonly bought over the counter. They could have gout, they could have menstrual pain, anything like that. So have to educate your patients who are taking lithium. Next, we look at pharmacodynamic DDIs. So these are quite common sense. When we talked about earlier, we gave the example of antipsychotics and Piriton, which is a very common flu medication. The pharmacodynamic effects can be additive, it can be synergistic, or it can be antagonistic. It depends. And it enhances or weakens the physiologic effect of the drug. I'm going to highlight two examples because, again, I said this is not going to be a comprehensive full list of all the possible drug interactions that you can see with patients who are taking psychotropic medications. It's just to give you an idea. So this particular one is important. I'm going to highlight two conditions: anticholinergic intoxication and serotonin syndrome. Anticholinergic intoxication is important because there's so many psychotropics with anticholinergic properties. You have your antipsychotics, including clozapine, olanzapine, copramazine with very high anticholinergic properties, and your TCAs like amitriptyline, which is what you would more commonly see, and clomipramine as well because it's used to treat obsessive compulsive disorder. Lotiapine, imipramine, not so much anymore lah. But you do see older patients who may have been on it for a very long time. So these have very high anticholinergic activity. In addition, yesterday we talked in Joanne's lecture, we talked about antipsychotic side effects kan. So for antipsychotic side effects like EPS, extrapyramidal symptoms, like hypersalivation, what do we do when patient experiences side effects because of a medication that we give them? We give them another medication, which is benhexo, which itself has its own side effects. So you see the problem here. We are giving cumulative doses of different drugs with the same sort of anticholinergic property, which can then lead to anticholinergic intoxication. So these are all medicines that we are giving patients to take. It's not just they are taking it on their own. And because of that, we have the responsibility to make sure that these medications are safe and they're not causing additional problems to the patient, right? So that is quite a heavy responsibility. So anticholinergic side effects or intoxication can be fairly mild, can also be quite serious lah. The very common side effects that we see are constipation. Clozapine causes constipation, Benhexol causes constipation, especially when you talk about older patients who are already have decreased bowel motility. It's all around a bad situation. They are already on bulk laxatives, they are on all sorts of laxatives, high fiber diet and everything, still constipation. And that actually affects absorption of other drugs as well as nutrients. So constipation may seem like a very, you just cannot go toilet, but it can lead to fatal consequences. Okay, so urinary retention is a problem as well with anticholinergic intoxication, blood vision, dry mouth, and I would like to highlight confusion, memory impairment, and delirium. So confusion, memory impairment, and delirium. Why I would like to highlight this? A lot of our older patients, those who are above 50, above 60, they are at risk, a particular risk for this sort of adverse effects, because we are looking at patients who have been on antipsychotics for many years, to their 50s and 60s. In addition, they are also on Benhexol. Okay, so apart from the constipation, which we discussed earlier, it increases probability of developing dementia, of cognitive impairment, and delirium. This is an extract from the American Geriatric Society Beers criteria. So this is something that this is a resource that you should be very familiar with if there are a lot of older patients under your care. It is a resource that is updated every couple of years, I think, and includes 5 categories of medications that are used in older adults. It lists down potentially inappropriate medications in older adults, potentially inappropriate medications to avoid in adults with older adults with specific conditions, and medications to use with caution. Medication combinations, which is what we're talking about today, DDIs, that may lead to harmful interactions, and a list of medications that should be avoided or dosed differently for those with poor renal function. Because we're talking about aging adults, pharmacokinetic parameters have already changed, renal impairment is probably there, hepatic impairment is already there. So very high risk, very vulnerable population of patients. And delirium can present as, can be missed because the patient, you think, maybe psychotic lah, or the patient is just old lah, confused, cannot remember things anymore, or maybe dementia. And itself, it can lead to a higher risk of dementia as well when you give anticholinergics cumulatively. Okay, this is my last slide. We're talking about serotonin syndrome. Serotonin syndrome is something that we do watch out for, especially for patients who are taking a lot of antidepressants. So basically, the name is quite self-explanatory lah. When you increase serotonin action in the CNS, this overactivates peripheral and central postsynaptic 1A, serotonin 1A and 2A receptors. And this, of course, happens when you give two drugs that have serotonin. Sorry, I'm having a bit of a... Okay, this happens when you give 2 drugs that have serotonergic activity together. And this isn't just limited to your SSRIs, your antidepressants. Remember, SSRIs, selective serotonin reuptake inhibitors. It also involves your SNRIs, things like duloxetine, your MAO inhibitors, which are not so common anymore. I don't know whether you have any patients in your site that are on things like moclobemide. It's a very old drug, it's been used to treat depression successfully, but because it's very problematic, a lot of food-drug interactions and drug-drug interactions, we don't really use it anymore. But we're also looking at patients who are taking opiates, pain medication, CNS stimulants, and 5-HT1 agonists, the triptans. Triptans are medications that are used to treat migraines, sumatriptan and all that. even dextromethorphan, which is quite a fairly common cough medicine, and again, St. John's wort. So this again leads back to the point where it's very important for us to do proper medication reconciliation, including things that people think are herbal or traditional medicines. You never know lah. Someone that you encounter, a patient might be already taking an antidepressant or something else, and then they neglected to inform you that some relative or some friend recommended that they take this herbal thing, and they don't know that it's called St. John's wort. They just know that it's something that can help them with depression, and then they come in with, serotonin syndrome. So it's important to kepo a bit. In this context, it is important to be kepo, to ask a lot of relevant questions, to find the best outcome and the best reason for why your patient is in hospital or there to see the doctor. Okay, final words: be aware of potential DDI. Be aware that I don't expect you to be a walking encyclopedia, to remember everything, to remember all the terms, the text, but be aware that something could happen. Whenever you see patients with very complicated medication regimes, as much as possible, especially in older adults, try to work with the prescriber as well as the patient to simplify. Is this necessary? Is this something that we could do without? Simplify. Monotherapy is always the best, but in some cases, it just cannot be avoided. Polypharmacy, especially in our psychiatric population, is a very common thing out of necessity. So if you can't, just work with it. Choose options that are less prone to DDI. For example, options that are not metabolized by the cytochrome P450 pathway. For example, for antipsychotics with haliperidone, for antidepressants, it would be desvenlafaxine. And discern what is clinically significant and what is theoretical. When you transcribe things in PHIS now, it will, before you move on to the preparation page, it will come up a whole list of interactions, right? So all of these were these electronic medical registers were supposed to help us make decisions, will alert us regarding potential drug-drug interactions. Long list, but not all of these DDIs are clinically significant. So don't be overly scared by it, and don't go running to the doctor and say, hey doctor, these two got drug-drug interaction, I don't think we should give together. You need to think, is this clinically significant? Do I have an alternative to offer before you even talk to the prescriber? Okay. And lastly, pharmacodynamic interactions are largely common sense. It's additive effects, as things that work together or against each other. So be aware of that. That's where your pharmacology does come in. Okay, we have some questions. Just want to finish with this slide. It's supposed to show you that there is a long path in pharmacy. Sorry, I'm having a little bit of dry throat. I've been talking too much for the past few days. Basically, stay curious, keep asking questions. You don't have to know everything, but you at least have to know that there's something to ask. Okay, so with that, I think I will end my presentation. Let's go to some